So welcome back to this new episode of the JCMC interview series. As always, I am Michele Introna, neuroanesthesiologist, Istituto Best of Milano, and together it's really a good pleasure that we have with us a great expert in neuromuscular blockade and anesthesia in general, Professor Thomas Fuchs-Buder from University of Nancy, North Hill, France. So welcome.
Thank you, Michele, for this kind introduction and for the opportunity to share this moment with you and the readers and the people interested in the GCMC.
So today we decided for the first time since we started our journey as podcasters, we decided to interview an author that published with us an editorial that we published in July 2025. That is Validity of Neuromuscular Monitoring Beyond the Technology's Precision. And the reason why we chose to start also talking about editorials is because we found it very, very clear and a very good starting point to make some reasoning about neuromuscular blockade. That is something we all do in our clinical practice daily, but it's always nice and also fun and also interesting to start from the basics and to talk about really like the things that the anesthesiologist must know when using and when especially when monitoring, and of course what's new in this field. So if you can just briefly explain to us what's in the editorial that we invite all the listeners to read, of course, but if you can make for us a short summary.
Okay. The editorial was written following a publication by a German group around Manfred Plobner that showed for the very first time that exact electromyographic neuromuscular monitoring requires also calibration. And this is completely new information, because until now it was almost thought that EMG monitoring would not need calibration. But this publication and the hype around different monitor technique was the opportunity to make the point that neuromuscular monitoring and this famous train of 4 ratio of 0.9 is not an absolute value, and we have to have a little bit information around it. What I want to say is we normally measure neuromuscular block at the adductor pollicis muscle on the forearm, but harm related to residual paralysis occurs at the upper airway. We know since many years that both muscles did not behave on the same way. These muscles here responsible to maintain the upper airway open are much more sensitive to neuromuscular blocking agents. In the clinical practice, that means you might have a patient that has recovered to a train of 4 ratio of 0.9 at the adductor pollicis where you are monitoring, but on the upper airway, he is still not completely recovered. So it is not an absolute value. You have to put it in the clinical context, and you need, unfortunately, some basic knowledges. It is not 0.9 is okay, and less than 0.9 is not okay. It is not black and white. It is 0.9 here does not correspond to 0.9 here. And 0.9 here is significantly more sensitive to neuromuscular blocking agents. You may have a persistent residual paralysis with the risk of pulmonary inhalation and subsequent postoperative pulmonary complications if you did not completely recover at the upper airway muscles. So that was the opportunity to make the point that 0.9 is not the holy grail.
So this is, from one hand, it might be, I mean, it's interesting and it's clear. On the other hand, I think, I mean, at least I felt a little bit scared, because we anesthesiologists in general, medical doctors, we try to focus on single numbers or single cutoffs, and everybody wants to know what is the cutoff. But in this case, it's something absolutely that we have to keep in mind, that monitoring means monitoring and connecting data with clinical and also pharmacology. The part in which you are talking about the PK/PD of neuromuscular blockers and the connection between PK/PD and the single value. So first of all, you said that 0.9 is okay, but we have to correlate 0.9 where, which is obvious, but it's nice if we repeat, because this is something we have to repeat more and more because it's a very important information. I'm a neuroanesthesiologist, so I know how important is the genioglossus nerve and all this kind of stuff, but also for the general anesthesia practice, it's very important that we differentiate between abductor pollicis and genioglossus nerve. But let's talk
Michele,
about...
you already mentioned, excuse me, you already mentioned the genioglossus muscle. Indeed, the genioglossus, for our listeners or readers here, is this small muscle here. That's because he is the one and only that maintains the upper airway open. So if the genioglossus is well, the upper airway is well. Unfortunately, the genioglossus is a small, shiny, very sensitive muscle that overreacts to neuromuscular blocking agents compared to the adductor pollicis muscle. But we need recovery of this small muscle here to maintain our airway open immediately after extubation. And you talked about PK/PD. Let me just say, to give two more pharmacological examples that should be taken in consideration when dealing with neuromuscular blocking agents to encourage or not to discourage our readers. It is quite simple, but it needs a little reflection, if I can say it like this. One is what we called in neuromuscular transmission, the so-called safety margin. Safety margin of neuromuscular transmission means that you have to block up to 80% of the acetylcholine receptors at the end plate, at the muscle end plate, before any measurable neuromuscular effect can be observed. In other words, you have to fill up these receptors up to 80%, and from that moment on, the paralysis will progressively be established. That means during neuromuscular recovery, you may have just 20% of receptors already free, and your train of 4 ratio will be 1.0. That means 80% of the receptors at the recovery may be still occupied by a neuromuscular blocking agent, and your train of 4 ratio is 1.0. In that particular situation, your patient is extremely vulnerable for any drug interaction. If you give, for instance, in the immediate postoperative period, magnesium sulfate to your patient who has just 20% of receptors free, and your train of 4 says you 1.0, all is fine, he will immediately have recurralization, because at that moment there's no safety margin. This is better if you reverse your patient, then you can reestablish some degrees of residual of safety margin. But in the unreversed spontaneous recovered patient, a train of 4 ratio of 1.0 might be, at least in the early postoperative period, a very weak indicator. And the second point, which is also important, is a famous study from a US colleague done in the late 1960s. The colleague name was Ronald Katz, and he gave 100 patients the same dose per kilogram body weight of a neuromuscular blocking agent, of the same neuromuscular blocking agent. And the dose would normally lead to a 50% of neuromuscular block. That was the dose per kilogram body weight that led to 50% neuromuscular block. In these 100 patients, there were 6 of 100 patients where no neuromuscular block could be observed. And on the other side, there were 7 patients with a complete neuromuscular block. The mean value was around 50% where you expected it, but we don't treat mean values in the OR, we treat individual patients. And in the individual patient, you cannot make the difference without neuromuscular monitoring between the patient that received the same dose, but he has no block at all, and the other one who received the same dose and he has a complete neuromuscular block. And in between both extremes, every single neuromuscular block could be observed in this study from Ronald Katz. So there is a large individual variability, which probably exists also with other anesthesia products like analgesics or hypnotics. And you as a neuroanesthesiologist probably are aware of that. But we know this for neuromuscular blocking agents since a very long time because we can measure them easily. It is much more complicated and was not possible in the late 60s to measure depth of anesthesia or to measure analgesia. This became possible recently only, and we realized there's also large variability. So this is normal, but the only way to overcome it is to monitor it. So neuromuscular monitoring is the best way to a personalized medicine. It's only like this, then you can adapt and monitor and follow your individual patient.
This is music for our ears because it's as the Journal of Clinical Monitoring and Computing, it's basically the mission. So the strong belief that unless we monitor basically everything, we cannot target drugs for our patients, and not only drugs, interventions in general. So once again, how important is monitoring in front of variability, inter-individual variability that still exists, will stay with us. So doesn't matter if we will use ChatGPT or everything else or artificial intelligence or whatever. We have to monitor stuff to know what we are doing. Absolutely, it's very interesting. And how is the state of the art in your opinion at the moment? So I mean, I think people is more aware. I have this. I mean, there are data regarding that people is more and more aware of the problem, but is there still work to do in your opinion, or we are reaching a point where neuromuscular blockade monitoring is quite spread among the users?
Would be nice, but isn't really. No, as you know, in 2023, the two largest anesthesia associations, will say the ASA and the European Society, published independently for the first time ever their guidelines. The great thing, both guidelines were developed completely independently. The US colleagues were not aware what we have done in Europe or what we have done in Europe, and we were not aware of what the US guys did. This is normally not possible because we know each other and there's a close collaboration. But these recommendations were developed during COVID. And there were no congresses, there were no exchange. And if you meet a colleague on Teams or Zoom, you talked about the ICU problem or the ventilation problem, but not about the guidelines. So, and thereafter, there was a common letter published in anesthesiology and the EGA of both societies emphasizing the need of monitoring and, if needed, reversal. So the recommendations and the data are there, but the implementation in clinical practice is extremely heterogeneous across Europe and across the world. We have in Europe some excellent countries, mainly the Nordic countries, that for historical reasons are far away with this implementation, and neuromuscular monitoring has become the routine. There are other countries. I recently reviewed a survey in Germany, where less than 20% of colleagues regularly use neuromuscular monitoring in their practice. So the knowledge is there, the data is there, but the problem is the implementation in clinical practice. So what we have to do over the next years, over the next period of time, we have to work to improve the implementation of the existing knowledge in clinical practice. And unfortunately, this is the most difficult part.
Yes, it's. I mean, I think we can all see it in our clinical practice. How good advices are always not listened by users, but we know that we can avoid postoperative pulmonary complications with this approach. I was interested
Indeed.
in a quite off topic, but possibly not very off. So the safety margin you talked about, uh, did anyone study why is there? I mean, what is the advantage from the evolutionary standpoint? Why is there is this safety margin, and why we are all done like that? If there is a why, of course.
Yes, so I think there is why. So we all ask the question, why is it like this? The safety margin gives you some safety to avoid that neuromuscular block is easily established. You have to block more than 80% of the receptors before your muscle becomes weak and relaxed. So it protects you for some kind of involuntary paralysis, because curare is coming from a poison from South America. It is in their real life was curare present. So it is a kind of inbuilt protection against involuntary curarization. But when the one who decided to do it, to make the programmation of us, did this programmation, he didn't thought on pharmacology, paralysis, and recovery from neuromuscular block. Because what is a kind of safety margin for the establishment of neuromuscular block becomes a kind of unsafety margin for the recovery of neuromuscular block, because you have our train of 4 is not performing enough to get more insights in the safety margin. If you make 100 hertz tetanus, you need more free receptors. Unfortunately, it is painful, and it is an examination that cannot be done repeatedly. We are lacking of a more performing test than the train of 4 for this, of course.
So this opens the last question. What's new? I mean, what we can expect from the next years in terms of new tools, or if you can forecast that, of course, if it's possible to forecast it in some way.
The good news is, Michele, and it is unfortunately not very spectacular. The good news is that we have everything we need to work safely and good. We have appropriate drugs. With Sugamadex, at least we have now a very performing reversal agent, and we have different technologies to assess neuromuscular block. So everything is there to work safely. We don't need nothing. There's no excuse. Go in the OR and make the job okay. But independently, there is ongoing research. There is less research in terms of pharmacology research, because the compounds we had are pretty fine working. There is much more work, the development currently in monitoring devices. Recently, electromyography is a new technology where we hear more and more, and it challenged it a little bit, acceleromyography, but both have their advantages, specific advantages and specific inconvenience. There's not one better than the other, but we have now a second technology ready to use in our OR. This is a good information, and independently on this, there are small progresses or small advantages. There's currently a first device that works completely without cables. It is only by Wi-Fi and by Bluetooth in the OR, and this is for an anesthesiologist who has IV lines and cables and things like this. It is practical. Another thing is that some groups are currently working on a kind of prediction. If you make your neuromuscular monitoring correctly for a 2 hours procedure, you measure during 2 hours every 50 seconds the state of your relaxation. But there is not any program for today that summarizes this information and makes a prediction how your patient will recover. In other words, we know that there is large variability. I talked before about it. Are we able, with a little bit of not artificial but real intelligence, to detect early those patients who recover slowly that would be great because you could better anticipate the slow recovery. And things like this are currently undergoing and will make it much more easier in the future. But the main problem remains the implementation of the existing valuable good technology in routine clinical practice.
So it's good now I think the listeners starts to understand why we choose to talk about this topic with Professor Fuchs-Buder, because it's so simple that it's almost awkward that we talk about it, but the reality is that we have to talk about this topic, and we have to convince people how important it is to monitor neuromuscular blockade. And talking with people like you, it really helps us to increase awareness, at least about this issue. So
That's it.
absolutely, thank you, because the time is running out. But this was really a super conversation. So thank you, Thomas.
Thank you, Michele. I'm happy about this format. The only thing I'm missing are the question from the audience now. That would be great if we could have a directly feedback from the colleagues.
But for that you should subscribe the YouTube channel, and we invite listeners and viewers to interact on the YouTube on YouTube. And also don't forget LinkedIn, Twitter. We have a LinkedIn account, Twitter account, X, Blue Sky account, and also Spotify. So please interact with us. And thank you to Professor Fuchs-Buder for the time he dedicated.
Thank you.